CataractCoach.com, podcast series, episode number 124 with Dr. Pradip Mohanta, teaching surgeons all over the world via YouTube videos. Welcome back to our Cataract Coach podcast. Today, I have a very special guest. You've seen his YouTube videos. We've all learned so much from his surgical techniques and tips. And that is Dr. Pradip Mohanta. My friend Pradip, welcome to the podcast.
Thank you. I'm happy to be with you.
Now tell us about your videos. You've been making these videos for many, many years.
Yes, more than 12 years.
Wow. And you have hundreds of videos, maybe even 1,000 videos. How many videos do you have?
I have more than 2,500 videos.
Oh, so you're like, wow, that's amazing. Amazing. And so how did you get started making videos? Obviously 12 years ago was a long time.
Yes, at that time it was very difficult to edit the videos. I used to edit with one software. I had to record my voice with another software and then mix the two. And sometimes sound lags the video goes ahead, sound goes behind. It was like that at that time.
Right. Yeah, for sure. People sometimes don't realize how much work it is to make just one video.
Yeah, yes.
Now tell us about the process. Let's say you have a very complicated case. And then certainly you get a lot of very difficult surgeries. If you have a very complicated case that takes you 30 minutes, how much time does it take you? How many hours to edit that video down, then do the voiceover and make the title slide, then upload it, then write the description? The whole process, how long will it take for one video?
Initially, it used to take about 1 hour for one video. And now I don't edit much. Mostly it is unedited. Just I add voice and it is not much time, maybe about 20 minutes for one video.
Wow,
But
that's fantastic. That's fast. That's fast. But if you have to edit a video, let's say you have a complicated case, though, then that obviously adds a lot more time to it.
Yes, it's a complicated case, and the surgery, if it takes about 30 minutes, then editing takes a lot of time. We have to eliminate the inactive time and then join the thing, and then it takes a lot of time, about 1 hour for one video.
Yeah. So which software are you using for the video editing now?
Nowadays, I'm using Adobe Premiere Pro 2021.
Adobe Premiere Pro. Okay. I use a program called Shotcut, SHOTCUT. It's very similar. All these editing programs are pretty similar. But the Shotcut is a neat program because it's totally free and it's available on any platform, PC, Mac, or even Unix-based machines. So it's totally free.
Shortcut. Okay.
So how do you decide now, because you have such a huge library of videos, how do you decide, okay, which video should I feature now?
Pardon?
Because you have so many different videos already, more than 2,000, how do you decide, okay, I want to feature a new video about this topic?
Nowadays, whenever I get, it's not new nowadays. It is addition of like intermission cataracts. I have many videos.
Okay.
And on more video, I just keep on uploading so that the viewers get something new. And every case is different. Every surgery is not like the other one, not like the previous one. There is some differences there. So it becomes a new one every time.
Well, okay, that's fantastic. So when you make these videos, obviously your main goal is to teach others. And which audience are you aiming them towards? More beginning surgeons, in the middle surgeons, or very advanced surgeons, or all of the above?
All. I make videos for all, and always my intention is to give my best so that they can learn. It's my intention is not to show that I can do it and it is difficult for the others to do it. Always all these videos are made with a lot of care and from good intention so that others can learn.
Right.
Not to show magic that I can do and you cannot do. Not like that. Always I have the good intention. My mission is to make good surgeons, and I want to make good surgeons so that patients get good vision.
Right. Ultimately, it's about giving our best to our patients.
Yes, yes.
How did you become an ophthalmologist? Were you always wanted to be an ophthalmologist? How did you land where you are today?
Yes, very interesting question. When I appeared at the final examination in our country, it is called MBBS.
Okay.
So in the final examination, actually, I failed in ophthalmology because
Wow.
I didn't read much this subject. Medicine, surgery, gynecology, big subjects. I
Yeah.
read a lot. Ophthalmology, a small subject. I didn't read much. And then I had to appear in the supplementary exam to pass the subject. During that time, a thinking came in my mind. It is in Sanskrit, it is called Sarva Indriyanam Nayanam Pradhanam, means eye is the main sense organ. And if anything happens to the eye, just a little foreign body in the eye, it gives lot of pain. And uh, I was in lab with ophthalmology when I was preparing for this supplementary examination.
Mhm.
And then I decided to take this subject and be a master of this subject. It is like
Wow.
that.
That's fantastic. But you obviously decided at a young age that you wanted to become a doctor.
Yes, I wanted to be somebody, not doctor, but wanted to stand on my own feet because I belong to a farmer's family, and my family was very poor, and I wanted to support my family somehow. Uh, I wanted to be the main earning member of my family. And my elder brothers, they wanted to be a doctor, and I said, no problem. Well, I want to be something in my life. Just like that.
And now look, you're world famous for doing ophthalmic surgery.
I don't know, but my mission is to make good eye surgeons. My mission is to make competent hands so that through those hands, patients get good vision. That is the main aim of my life.
Right. I think that's a very noble cause because in your own hands, you can help thousands of patients per year. But when you teach such great lessons to other surgeons, you can help
Yes,
millions of patients a year.
yes, yes.
And speaking of which, your videos now have many, many millions of views.
I think so. There are many viewers, and wherever I go in any clinical meeting of ophthalmologists, I get many doctors coming to me, and they say that I watch your videos and I learn a lot of things. My surgical techniques have improved. I feel happy to know all those nice words.
Yeah, listen, I feel the same way. It's really, especially it's all ages of surgeons are appreciative, but especially the new generation.
Right, right.
And I think the new generation, they're very fortunate because they can learn in 1 year what took us 10 years.
Yes, yes,
We had to learning from our mistakes, etc. But the young surgeons, anywhere on the planet, on their mobile phone, can
yes,
watch the videos in high definition. They can learn from our mistakes and
yes,
prevent the issue.
yes, yes. And it's true. Well, in our time, there was no YouTube videos. We had a very tough time to learn. I
Right.
remember I started FECO and in our upper Samis machine in a on a modest microscope. And next day, the cornea was white. There's severe corneal edema. And I left FECO for 1 year.
Oh,
Then
wow.
I got another good microscope and I tried again, and I went through many complications. There was no teacher. I had to teach myself.
Right.
And many complications like corneal edema, postcapsular rents,
Mhm.
nucleus drops, all those things happened. And learned from my own mistakes and gradually, uh, became a surgeon.
You
Now
had
they Now they have everything. Now they can get guidance from our videos. your videos are so fantastic, and you make videos in such a short time, 5 minutes, 7 minutes videos, and they learn so much. I have learned so much from your videos. Thank you very much, Uday.
Oh, my pleasure. But I think the key is we all learn together.
Yes,
I learn much more than I teach. I mean, that's the truly amazing part of it. I mean, I subscribe, I watch your videos too.
thank
Because
you.
there's something to be learned there. I make the videos very short, only 4 or 5 minutes, because I spend a lot of time studying my metrics. And I know if 100% of people start watching a YouTube video, I want to know what percent are there halfway through and what percent of them stay till the end of the video.
Yes, yes.
And so if I make too long of a video, if I make a 12-minute video, I think the attention span in the modern day planet is very brief. So
Yes, yes.
if I make a 12-minute video, maybe 20% of people will watch till the end.
Mhm.
So it's actually available on YouTube. You can look at any video and see the metrics, and you can see where it drops off. They call the decay rate.
Okay, okay.
And then they'll plot out what's your average decay rate. They'll show you this video. So then I can say, okay, what makes it better, what makes it worse, etc. I've learned a very important lesson, which is on YouTube, I have to show something really exciting or eye-catching within the first 30 seconds if I want really great performance.
Okay.
But when I post the same video on Instagram, I have to show that within 3 seconds. Otherwise, they swipe to the next thing on Instagram. So that's that's a big change there. And then on Instagram, I put the same video. Every day I put the same video. I put a new video every single day. And I put the video on YouTube, on CataractCoach.com, on Instagram, on Facebook, and on LinkedIn. Every day it goes to all the above.
Okay.
But the only video that's a little different is on the Instagram video, I have to cut right to the action. Like if the video is about a broken capsule, I have to cut to within a few seconds of when the capsule breaks to catch their attention. And then the overall video on Instagram is only allowed to be a few minutes. So it has to be a shorter video.
Yes,
So now
yes.
it's more work. Now I have to have a special edit for Instagram. Plus on YouTube, we do things in portrait, in landscape mode. So the widescreen format. But when you put the same video on Instagram, they want it on the portrait mode, which is like your phone size, which is the narrow. Or it's become like a lot of work.
Yes, yes. I put on YouTube and Facebook. I don't put on Instagram, but I think I should put on Instagram too, because the young generation is on Instagram most of the time.
Yeah, my advice is to also put it on Instagram. So my current views, I'll get more than 1 million YouTube views a month, but
Yes.
I'll get more than 1 million Instagram videos a month too.
Yes, yes.
And so they're a little bit different populations.
Mhm.
So I think when people want to really study a subject in depth, let's say they have a posterior polar case coming up next week or tomorrow, then they tend to go and watch a lot of YouTube videos, and they may watch 3, 4, 5, 6 posterior polar videos in a row just to see everyone's techniques.
Mhm.
But if they're just looking on a daily basis, they tend to just kind of, what's new today on Cataract Coach? Okay, then they like Instagram because they're already on Instagram every day, and then the video just shows up in their feed. They don't have to go and look for anything.
Right.
So it's just a changing world. I have not done TikTok because I'm afraid of putting TikTok on my phone.
No, I have not tried TikTok.
But I think, yeah, it's a new way of certainly teaching. And I think you're right. You said when we were in our training or earlier part of our career, we had to learn from our own mistakes. And
Yes.
you didn't have this immense library of videos to teach you.
Yes. I remember when I was doing extracapsular cataract surgery with IOL implantation from 1994 till 1999.
Okay.
5 years. I was very good in extracapsular surgery, putting good stitches, continuous sutures, interrupted sutures. I was very good in suturing, and results are very good. But then there was a live surgery conference in North Bengal, in our state, in West Bengal. And Dr. Haldipurkar, Suhas Haldipurkar, he came there and showed live surgery, phaco live surgery. And there was a beautiful golden ring, and the surgery got over in 8 or 9 minutes. And I thought, wow, this is the surgery I should learn. I got tremendously inspired, and then I thought that I should learn this surgery. It is better to not to put suture than to put good sutures. So I tried and tried, and I went through many complications, but ultimately I could learn.
Yeah, it was tough. I mean, I still remember back, we didn't have access. There was no video library. We had Bobby Osher's videotapes every quarter, every 3 months. He had the Video Journal of Cataract Surgery, which was such gold to me. It was to me, I loved it. But I couldn't find the tapes all the time. I had to borrow the VHS tape from one of my faculty members, go home and watch it, but then I had to return the tape. I didn't have continuous access to it.
Yes.
And as a young surgeon, because those were very expensive tapes at the time. And so it was really neat to have the advent of YouTube to have all these videos available for us. But I think we have to definitely say thank you to our the godfathers of video, like Bobby Osher. To me is the godfather of surgical video. I've learned so much from him. But I still remember back, gosh, maybe in the year 99 or 2000, I'm doing cataract surgery, and I didn't realize that it's not PSC. It's not posterior subcapsular. That patient had posterior polar. And I do a hydro dissection. The capsule splits. I see there's a snap sign, but I don't even realize it because I didn't know what snap sign was.
Okay.
And then I start the phaco, and next thing you know, the nucleus is in the vitreous. And I said, what did I do wrong? I didn't even know. And it was only later that evening after I sit there and look up things and, oh, this is what they had. And then even for me to find other people's videos of, well, how do you do posterior polar? I had to find books, and I'd read about it in the books. Or you do a Medline search and you'd see an article. I saw one by Abhay Vasavada saying that posterior polar had 30% breakage rate of the capsule. And I said, oh, no one taught me this. So my patient had to suffer because I just didn't know, and no one taught me this. But I think now there's almost no excuse. You have a posterior polar case coming up, you need to go study it yourself.
Yes. And now the material is in the phone. Everybody can have it here.
That's really, I think it's equalizing, it's democratizing surgical education. And I think that's a really neat thing. You're fortunate. In India, when you do your training, there's a huge volume of surgery you can do. There's unlimited supply of patients, unlimited. But sometimes people train in like certain European countries, especially, they may not get any surgical volume to do their whole ophthalmology training, and they've done a handful, sometimes even very few, almost no cataracts. And then I don't know, how do they learn? So it's funny, when I came, I saw at a meeting in India recently, and surprise, surprise, they're like European residents there. They've come to learn. Now, do you offer a program like that too, to train outside residents who want to come spend a week or a month with you? Do you offer some sort of fellowship?
When I was a resident in ophthalmology, I did my residency, 3 years ophthalmology residency at PGI Chandigarh. At that time, situation was different. Nowadays, it is advanced eye center, and the residents are getting a lot of chances to do surgeries. But in my time, only senior residents were getting chances. So we, the junior residents, we are not getting chances. And I remember in 3 years, I got only 3 surgeries.
Wow.
So I didn't learn anything. And from there, from Chandigarh, I went for a vitreoretinal training to Shankaranathalaya, Chennai. I was a fellow in vitreoretinal surgery for 1 year, and there I learned core vitrectomy and how to. That training was very good for to manage posterior capsular rents in my practice.
Mm-hmm.
But after completing my training from Shankanetla, I found that I don't know how to do cataract surgery. I came back to West Bengal and I found that I have no job. And then I was with Dr. Devashish Bhattacharya. He is ex-president of our Ophthalmological Society, Indian Ophthalmological Society. And I was with him for some time. He supported me. And he told me that you have to start practice in a small town and you will get more patients to do
Right.
surgery. So I came to Ranaghat, a small town in West Bengal, and I was in in optical shops initially. Then I took a house on rent. I started my practice in that house, and then I started getting patients. And observed Dr. Devashish Bhattacharya how he does ECC, and I just observing I had to learn. So
Mm-hmm.
I started doing ECC. At that time, it was easy. Can opener capsulotomy, remove the cataract, wash the cortex, put the lens, and suture.
This must have been mid 1990s.
1990, 1990. Oh, yes, mid 1990,
Yeah.
that time. So those tough times.
So then you set up a small in this house. You set up a small practice, and then it
Yes,
started to grow and grow and grow. And then tell me more how it grew.
yes. I started small. I took a place on rent, and then I started practice. And there was this two rooms. One room was for patients, or means for as outpatient, and another room was for operations.
Okay.
So in this way, I was there for about 4 or 5 years, and then that place was small and it is not a good place to do surgery. So by the time I bought another land and made a house, in that house, the ground floor was OPD, and the first floor was ward and operation theater.
Right.
And it was a good setup. I had Apasamis microscope initially, and then Inami microscope from Apasami, and later on I got Leica microscope from Switzerland. And when I got a good microscope, and after that I got the recording system. When I got the recording system, I found that my surgery is very boring. I am wasting a lot of time. There is a lot of inactive time. Then I could audit myself and improve my surgery.
Right.
So I will say to the surgeons that as soon as possible, you get your recording system. If you are if you want to do good surgery, you have to see your own surgery and audit yourself. And you have to know where you are killing time, where you are wasting time, whether you are doing any unnecessary manipulations within the eye or not. All these things you have to know.
Right.
So from there, from that house, the practice became good. I have had some colleagues, and then we bought a land in the main town and started our new hospital. It is Netrojyoti Eye Hospital now, and now we see about uh, 300 patients in a day, and we do about 400 surgeries in a month. So it's a good setup now with all machines. We have vitreoretinal setup, glaucoma surgery setup. Everything is there now.
Well, fantastic. Now, do you have associates, surgeons with you as well?
Yes, yes. I have associate surgeons, vitreoretinal surgeon, glaucoma surgeon, and cataract colleagues. They are there, medical retina colleague. I have all those associates.
You probably never could have imagined back when you were younger,
Yes,
working in the back of someone's small optical shop. You would have
yes,
never dreamed that one day you'll have your own eye hospital doing 5,000 surgeries a year.
yes, yes, yes. Never imagined that.
So that was fantastic advice of going to a small town that
Yes,
really the small town needs you there. There's no one else.
yes.
That
Yes.
was a great advice.
That was a really good advice.
Yeah, we should echo that voice and that sentiment and teach the new generation as well. That's
Yes,
a great way of doing it. You will. It's almost a guarantee. If you go to a smaller town where there is no ophthalmologist, there's certainly a
yes,
need for an ophthalmologist. You will, by definition, become much, much busier.
right. You'll get work. In main city where there are hundreds of ophthalmologists, you will compete with them and you will get very few patients.
Yeah. Some people, when you're young, you don't realize that sometimes the biggest challenge is not the surgery. It's actually getting the patient to come into your clinic.
Yes, that's true.
Right? When you're training, you never realize that. And it's funny, even though we are significantly older than the new generation, I mean, we were doing surgery before they were born. The new ophthalmologists today who are in their training, the registrars, residents, I mean, they weren't even born when we were operating.
Mhm.
These same lessons are actually very true throughout.
Right.
Another part I really liked, I loved your advice that you'll never start learning or becoming a great surgeon unless you start recording your videos and watching them.
Yes. You have to record your own surgery and you have to watch your own videos. Then you will realize that how good surgeon you are. There may be a lot of time you're wasting. Your sister is giving the next instrument after a lag time of few seconds, which is not necessary. The next instrument should be ready. As soon as you finish a step, the next instrument should be in your hand. There should not be any time gap between these two steps.
Oh, totally agree. And that's part of your job too now is to train your team.
Hmm.
You've got to train your assistants, make sure they understand how to do things right.
Right.
But I think, yeah, watching your what I call your game day footage, watching videos of you operating is really the only way you can be self-critical and dissect that so that you understand, okay, what could I do better? I mean, even professional athletes will watch videos of them playing the sport. They can go back and study and say, okay, what could I do better? And it's that constant drive to be better and better and better that's going to make you a better surgeon.
Mhm.
So if you're a young surgeon, certainly the most important thing you do is watch your own videos. If you go in the operating room, you better have an ability to record your videos, bring your USB memory drive, your memory stick, record all the cases, go home and watch them. And for every case you do, write down what could you do better? What did you do okay? And say, okay, what's the next step? And I think if you have that constant drive to be better and better and better, you'll become better.
And once you become better surgeon, good surgeon, don't keep this skill within you, because if you keep your knowledge, skill within you, if you don't teach, you are going to take all your knowledge, skills to your grave.
Right.
So you must die empty. You must give out whatever you have learned, you must give out to the next generation. And the thing is, unless you teach, you are not doing justice to your life.
Right.
Because
Of course. Yeah. If you teach, you can help far more people.
yes, and
It's such a waste to accumulate great knowledge and then die with it.
yes, you must not die with knowledge within you. You must give it out. So, if you think that you are a good surgeon, you are doing good things, you have developed some skills, you must share it. Nowadays, you don't need a podium to share it. You can open your own channel in YouTube or any other, and you can share your videos.
Yeah. I think that's an important point. When we first started, the only way to share your videos was to be at a big meeting. And even at a big meeting, if you got very fortunate to get 5 minutes to present at a large
Yes.
meeting, At most, there are 500 ophthalmologists in the audience.
Yes. And nowadays, wherever I go in meetings, I see more people outside. In the halls, there are very few people
Yeah,
because all.
true.
So, uh, in our time, we had to be inside the hall, listen to what the speaker is saying, only 5 minutes or 7 minutes, and that's it. You will not get another chance to see those things.
Hmm.
But now you upload a video in YouTube that is seen many times, many months, many years by so many viewers. So it is, podium presentation has limitations. Whatever, unless you share in internet, unless you share somewhere in, unless you have your own website or some platform, YouTube or Facebook, or wherever it is going to get lost, no? And you have shown it to some 500 people or 100 people, and they will forget.
Right.
If it is there, they can again watch and learn the thing again. So we have to share our skills on a good platform like YouTube or any other good platform.
Right. I also like the ability to go back and see how I used to operate because I've changed. I found a video of me operating maybe like 15 years ago. And it's on YouTube. If you look carefully, you can find it. And it was a routine case. And at the time, I was so naive. I was so stupid that I thought it was so good that I could hurry up and speed through a cataract in 3 minutes. But I watched the video now. In fact, I critiqued the video on CataractCoach. I put the video up and I critiqued it again, and I said, "This is not good. If it's my eye, spend an extra 2 minutes and make it beautiful. It's craziness." But at the time, I just didn't have the clarity of mind. I thought the goal was to be faster and faster and faster, which, as you know, and I know now, that's not the goal.
Yes.
The goal is to be better and better and better and make the surgery even prettier, not faster.
Yes. Yes, yes. You have to be artistic.
Tell us about the balance of efficiency versus like speed for a surgery, because you do a large volume of surgery.
Mhm. Yes, we have to be every time we have to do better than the previous one. Always we have to have that drive within ourselves that I will be a better surgeon, I will be a better skilled person next day.
Right.
I will, and we should not stay with one technique and just limit ourselves to one technique. Like we can do cataract in divide and conquer technique.
Right.
But we should not limit ourselves to only to that technique. We must try other techniques and do it quicker, faster, and safer way. If we are inside the eye for longer time, it is going to cause more damage to corneal endothelial cells.
Mm-hmm.
So if we are doing a direct chop, if we are, I have a technique, submarine chop, where I use the ultrasound within the substance of the nucleus. So the ultrasonic energy is not going to the corneal cells, or not going to the corneal endothelial cells. All the ultrasound energy is within the nucleus. And the nucleus get cracked without any trench. And within 1 or 2 minutes, I can divide the nucleus into several pieces in hard cataracts. For soft cataracts, I have a pre-chopper technique where I can divide the nucleus into 4 pieces in 30 to 40 seconds.
Mm-hmm.
In soft cataracts, if you use other techniques, like if you try to hold and chop, you will not be able to hold because it is soft. If you try to hold, the matter in front gets eaten up. If you want to make a trench, the matter gets eaten up so fast, and you are always worried, I'll reach the posterior capsule so soon and I may touch the posterior capsule. So if you have measured instrument, like this is the pre-chopper, it will go to this depth. I have the nucleus sustainer, it will go to this depth. I'll bring the two instruments together and separate. It is much safer. I can tell you that in my pre-chopper technique, in soft cataracts, I don't remember a postcapsular rent after I started this pre-chopper technique. But I had made many rents in in soft cataracts. I think, made more postcapsular rents in soft cataracts than in hard cataracts.
Yeah.
But with this technique, now I divide cataracts into two categories. Whether you can hold it with vacuum or not. If you can hold it, do direct chop. If you can't hold, do pre-chop.
Right.
So,
So that's an important distinction here. I like your idea that you say you must learn all techniques. You can't just use divide and conquer. You must know divide and conquer. You must know a horizontal chop, a vertical chop, a pre-chop. You stop and chop. You must learn all of them.
yes, you must try. You just don't limit to one technique. The problem is, in big cities, they don't get a low-paying patients. They get all high-paying patients. And
Okay.
they don't want to try new techniques on those high-paying patients.
Mm.
The surgeons are confident in one technique, and the surgeons will remain on that technique. But in small town, we get many patients who cannot pay. We take utmost care, but at the same time, we can try new techniques on them. So the patient is not paying money, but the patient is paying, they're giving us experience. Patient is giving us something.
Right.
So in that way, if you are in a small town, if you get low-paying patients, if you get free patients, where you get the drive to take, try new techniques. But in cities also, if you are, if you don't, I would say that don't limit to one technique, because you are a surgeon and you can always put a threshold that I will go to this level, and after that I will come back to my comfort zone.
Right. Right. That makes a lot of sense. So in your clinic now, you must have the full spectrum of patients, from free, low paying to even high paying patients. You must have everyone. You have the free patients coming in, the low paying, the high paying. How is that split up in your clinic?
Please repeat the question. I was distracted a bit.
Sure. In your clinic, you have free patients,
Yes,
low paying patients, high paying patients, VIP patients, in the whole spectrum.
yes, I understand. In our setup, this is a small town and surrounding villages. And in out of 100 cases, I'll have probably 10 patients who can pay premium lenses. About 30% patients will pay, aspheric hydrophobic lenses. About 30% patients will pay Indian foldable lenses. And the rest are very poor. They don't have any option. Whatever you put, they cannot pay. So about 20% patients are very poor in our area, and they can't pay. So what I do nowadays, I get trainees from all around the world.
Okay.
I get from a lot of countries. I have trained almost 100 international candidates. So the candidates pay for those free patients.
Mm.
And I stand beside them and I teach them. I have the Lumera T microscope now. Lumera T, where the observer microscope is very good. And sometimes I hold their hand so that the eye is safe. They don't go to dangerous positions. It's very good microscope. The observer microscope has got full depth perception, and it has got independent focus for the observer. I think you know Lumera T from
Sure.
JAIS.
Sure.
The Lumera 700 also has the same.
Then the international fellows who are coming there are basically able to help you do the free cases, and you teach them as they're
Yes,
operating.
yes. So the free patients are not paying, but these international fellows, they are learning on those patients. But I take full care that I must get vision. They must not move, no, do any dangerous manipulations inside the anterior chamber. I always, every second, I observe and what they are doing. Once I am sure that he is now can do independent surgeries, only then I leave the hand. Otherwise, and I get many national candidates from India. Right now I have two candidates, and I thank Sun Pharma. Sun Pharma is sponsoring those candidates, Indian candidates now. No, the candidates have not to pay, but Sun Pharma will pay us on behalf of those candidates.
Great. That's great. And the patient who has no money to pay pays by letting you learn and advance your techniques.
Yes.
So everyone wins. Everyone's happy.
Yes.
Oh, that's fantastic. Now, for a young surgeon who's doing training today and is having a difficult time becoming a good surgeon, what advice can you give that young doctor? They go to the operating room, it just seems so difficult. They're just not getting good results. Their hands just don't work the way they want. What advice do you have for them to become better?
I did only 3 surgeries in 3 years of residency.
Okay.
But in those 3 years, I did something else. After these surgeries are over, I used to take a 10-0 nylon suture from sister. I used to cut a gloves, and I used to think this is a corneal tear. And I used to suture that gloves, that cut injury, with a 10-0 nylon. I used to call this dry lab because there is no animal eye that.
Yeah.
So you have to get oriented, orientation, hand, brain, eye, hand, everything has to be coordinated. It's a training. So if you just do suturing under microscope, it's a small cut on a gloves and suture with 10-0 nylon, you are learning something.
Mm-hmm.
And if you have that drive that I must learn, I must make my hands stable, spend time with microscope, spend time with suturing, spend time with animal eyes, put incisions, do rexis on goat eyes, and do some steps, put incisions, side put incisions, main incisions. SICS, you can make that corneoscleral tunnel on animal eyes, do all those things. If the real human being the patient is not available, even then you can do a lot of things and then prepare yourself.
Right.
The main thing is you have to have that drive that I must learn, and you have to believe that I am psychologically fit and I am a mentally alert person to learn this surgery. I can learn it. If you have that belief, and if you are really without any problem, like not much of tremor, you are not a nervous person, then you can learn. I like a quote of Dr. Deepak Megur. He says, there are 3% surgeons who are, genius. They can do anything. And 3% surgeons are awful. They cannot learn surgery. But the 94% surgeons, they can learn. If they have the drive within themselves, they can learn. They have to try and try. Never give up. Always persist.
That's great advice. It's interesting how your advice of suturing is the same advice I give. My criteria was to go and practice, get a tomato, a little small tomato, or a grape, cut it, and suture it. And my benchmark was, if you're a good resident, you should be able to do 10 sutures of 10-0 nylon in 10 minutes.
Oh, that's good.
I call it my my 10-10-10 rule: 10 sutures, 10 of nylon in 10 minutes. And then
Yeah.
after you told me they should be very pretty sutures.
Yes, yes. It should be pretty sutures, radial, not oblique, nice sutures. It has to be.
Right. But I think in most cases, you have to practice at least 500 sutures to have that ability.
Yes. Phaco is sutureless surgery, but you are learning, you are training your hands, you are training your hand muscles, you are training your brain under microscope, you're developing your depth perception, everything you are doing without the patient, without the real patient.
Right. It's
And
learning how to use your hands for sure.
yes, and suturing is so important. Suppose you are a surgeon and a corneal tear comes, what will you do unless you know good suturing?
Right. Yeah, for
Corneal
sure.
tear. It's
For
not
sure.
cataract surgery. It's a corneal tear. You
Right.
have to suture the corneal tear. So any ophthalmologist must learn good suturing.
Agree 100%. Absolutely. That is great advice. Now, you also have a very interesting philosophy. In all of your videos, I always notice in the top corner, you have a little deep, a little light.
Yes, yes.
And
Uh,
you always say, let's do better, see better. Tell me about all this.
yes. That is the symbol of a lamp and it is, my name is Pradip.
Yeah.
Pradip means a lamp. And that light means we want to give light to blind eyes. That symbol is with that intention. That is small lamp is there. And do be better and do better. See, that is the every day you learn something new, and every day you put yourself to some challenge and
Right.
overcome challenge and be a more competent person, be a better person, and do better. The thing is, if you do better, ultimately the patients will get good vision. That is my aim.
Mhm.
I have to develop good surgical hands so that patients get good vision. I think you also have the same mission.
For sure.
So thousands of surgeons are learning through our videos, your videos, my videos, Deepak's videos, Saurabh Patpardhan, Sunil Tangaraj. So these videos are great assets.
Right.
So they learn and they give good vision to patients. Many surgeons, actually good surgeons, they learn just by observing. They need not come to you, they need not come to me.
Right.
Just by observing, they can learn. Some surgeons need some hand holding. And there are some surgeons, even if you hold hands, they will not be able to learn that those 3% surgeons. But 97% ophthalmologists can learn surgery if they keep on trying.
Mm-hmm.
And we have to put ourselves always in some challenge to be better, more competent. I remember a grade 3 cataract. I
Okay.
used to do in 15 minutes. Then I thought, how can I shorten the time? At the same time, I must not compromise the safety. So I just cut off the that time, that lazy time that I'm not doing anything. And surgery time comes to 12 minutes, and then I this movement I do in 5 seconds. Can I do it in 3 seconds? Yes, it is possible, and it is rexis, capsular rexis. If you do it slowly, it doesn't become round. You
Mm.
have to have a minimum speed. So if you do at a certain speed, it becomes round and nice. If you are slow, go slowly, it goes this way and that way. It doesn't become a nice capsular axis. So a speed is good, but at the same time, we must know that this is the limit. We must not cross the limit. We must not cross the safety limit. Must not cross the threshold. And nowadays, I can do grade 3 cataract in 5 minutes, 6 minutes.
Sure.
Yeah. But next day, cornea is crystal clear, feel happy. We can give the spectacle prescription after 5 days, 6 days, 7 days. So nice. So we have to put ourselves in that challenge that every day must be a better surgeon. Every day, everybody, every ophthalmologist should aim for this. I must be a better person next day. That is my. That's why I write, do better, be better.
That makes sense. I mean, obviously it makes sense. Nice part is like a good surgeon, like you, like me, like all of your friends we've mentioned, we do that philosophy in our heart. Every day we want to become a little bit better. Every day.
Yes.
And the magic of the compounding with time is that 1% better a day is a lot. Heck, 1% better a week is huge, right? Because if you, even without compounding, after a year, it's 50%, but you compound it, it's even more. So you can be twice as good in less than 2 years, which is just amazing. But only if you commit to learning all the time. You have to learn every day.
Right.
So that's important. I love that philosophy. Yeah, because I noticed that. I said it's in all your videos. In all your videos, you have the little light, the little lamp, and then all your
Yeah.
videos you say, "Do better, be better."
And give light to, give vision. Light means vision to the blind eyes.
That's what a great philosophy there. Now, I sometimes get emails from young surgeons who are really struggling, and they're considering stopping doing surgery and just do medical ophthalmology. What advice do you have to that person? How do they know if they're in that 3% that is going to have a hard time or not?
Uh, the surgeon is not able to control his own thinking. He is not able to control the hand movements. Those are the surgeons probably you can ask them to be a medical ophthalmologist. There's no harm in that. There is, the medical retina is there. There is uvea is there. There's medical ophthalmology is very nice. But if you be a surgeon and if you think that your hand is not listening to your own command, then you should think that I better be a medical ophthalmologist. I want to hold this, but I am not, my depth perception, I am not able to develop. I cannot hold it. My left hand is not listening to my commands. My left hand is, doing dangerous movements inside the eye. And I am not able to control my manipulations. Those surgeons may think that, okay, let me uh, think of medical ophthalmology, medical retina, uvea, and be an academician like that, a professor or teacher, fine. But
Right.
otherwise, most of the surgeons, maybe 97% surgeons can learn surgery if they have the drive and if they can control their hands, if their hands are stable, if the hands listen to their own commands, then they can be a good surgeon.
That's great advice. Great advice. I think, yeah, don't give up too easily is my advice too. Don't give up so easily. Go practice like you were saying earlier. Do the 10-10-10 sutures and then
Yes,
start from there. And if you're having trouble with the non-dominant hand, let's say the left hand, then do everything in the daytime with that hand. Brush your teeth, shave your face, eat your food, do everything left hand. Just to
right,
build up that connection with the brain so you have better control.
right. And about that, how to be better every day, soft cataracts, the many surgeons will sculpt and make a bowl at the center,
Mhm.
and then there is no place to hold. And it's a very tricky situation. I used to do that. I have done that earlier, and particularly the diabetic gummy cataracts, where
Okay.
you make it trains and it doesn't want to separate. Then I thought of this pre-chopper technique. It is not a new technique. Dr. Akahoshi is doing it for so much time. Long back he started. But that Akahoshi was pre-chopper was, I tried it, but I could not master it. Then I thought of this kind of pre-chopper. You have a nucleus sustainer in one hand, the pre-chopper in the other hand. You give support to nucleus from both sides and bring the two instruments together and separate. And now the soft cataract management has become just a piece of cakes. You just cut a cake. In South India, there is idli. You know what is idli? It's just like you cut the idli into 4 pieces and then eat up the pieces. It's like a soft cataracts. It has become a joy to manage with this pre-chopper technique. So I will advise all surgeons. The trainees, they learn pre-chop just after 4 or 5 attempts. Just after 4 or 5 attempts, they learn the pre-chop. And all of them are doing pre-chop for soft cataracts. So this technique must be popularized because it is much safer than making trench, trying to hold the soft cataracts. This is another message today through in this podcast. Learn pre-chop for soft cataracts.
Plus, remember, the soft cataracts are more likely to be your premium patients who
Yes.
they want the EDOF lens, they want the trifocal lens. If you break the capsular bag, now you can't put in the lens they want.
Yes. And other techniques, this you make a large rhexis and prolapse the soft cataract and emulsify it in the anterior chamber. That is not good for premium lenses. In premium lenses, you need a 5 millimeter rhexis so that the lens is the anticapsule overlaps the optical rim.
Right.
So,
no, it makes a lot of sense. I love it. Great idea. Are there particular pre-chop instruments you use?
Yes, I have designed my own pre-chopper now. It is a pre-chopper. This front edge is the cutting edge. The back surface is blunt. And the bottom is also round, thin but round. And the sustainer has a ball at the, like NATO's chopper, NATO's ball tip chopper. It has a ball, and this is 1.8 millimeter. The pre-chopper also, from the bend, it is 1.8 millimeter. And it goes like this, go under the rhexis margin, hook, and this one goes just in front of the rhexis margin, bends up to the bend. You just go up to the bend, bring it to each other and separate.
Easy peasy, very easy, nothing to it. And you usually split to 4 quadrants and then remove them?
Yes. Even if you just divide one heminucleus, other heminucleus can be easily chopped. It comes to the center of the eye and you can chop it easily.
That sounds weird. Well, you know what? Give me a video that I'll feature on Cataract Coach. We'll have your podcast up on a Sunday. You can send it later. Don't send it now. We've already been talking for an hour. I can't believe it. We've had so much fun. But we'll feature your podcast coming up on a Sunday, and then the following Monday, we'll feature your video. And we'll also put a link in this podcast in the description. There'll be a link to Dr. Mohanta's YouTube channel, also to his website if you want to contact him. Certainly, if you are wanting to come to West Bengal and learn surgery from the master, he's willing to teach you.
Yes, now, I'll give a video where the first part will be for soft cataract with pre-chop, and the later part will be submarine chop, and it is just 4 minutes. Just 4 minutes.
Perfect.
And this 2 minutes and 2 minutes. It will be just 4 minutes. I'll send it to you so that it can be shown in this podcast.
Happy to feature it. Thank you so much for doing the podcast. I really sincerely appreciate it. I've learned so much from your videos. You're doing a fantastic job. Please never stop. Keep making more videos, and we have to get you on Instagram also. You may have to ask your children to help you, but they'll teach you.
Thank you.
You're welcome. I want to remind our listeners and viewers, remember, got a new Cataract Coach podcast every week. Check it out. It's on Apple, Amazon, Spotify, Google. Everywhere you find your podcast, you find the Cataract Coach podcast. Plus, remember, of course, we have a new Cataract Coach video every single day. So until next time, I'll catch you later.